Getting a good X-ray is a bit like taking a really important photograph. You wouldn't just point and click without thinking, would you? The same principle applies here, but with much higher stakes. Proper patient positioning is the cornerstone of a useful diagnostic image. It's the difference between seeing a clear, detailed picture of what's happening inside the body and getting a blurry, distorted image that tells the doctor very little. When a patient is positioned correctly, the X-ray beam can travel through the specific area of interest without obstruction, revealing the bones and tissues in their true size and shape. This precision is absolutely crucial for an accurate diagnosis. Think of it this way. If a patient is slumped or twisted during a chest X-ray, their ribs might obscure a part of their lungs, or their heart might appear larger than it actually is. This could lead to a misinterpretation, causing unnecessary worry or worse, a missed problem. Good positioning isn't just about getting a pretty picture. It's about ensuring the information the doctor receives is reliable. It also plays a vital role in patient safety. By aligning the body perfectly, we can target the X-ray beam precisely, minimizing the radiation dose to surrounding tissues. It's a simple step with a profound impact on both the quality of care and the patient's well-being throughout the process. Making the patient feel comfortable and secure is just as important as the technical aspects of positioning. A relaxed patient is more likely to hold still, which is essential for preventing motion blur on the final image. Imagine trying to take a photo of someone who is fidgeting. The result is never sharp. We can achieve this by explaining each step in a calm and clear voice, using pillows or foam supports for comfort, and offering a warm blanket if the room is chilly. These small gestures of care build trust and help alleviate any anxiety the patient might be feeling about the procedure, making the entire experience smoother for everyone involved. Ultimately, mastering patient positioning is a fundamental skill that directly translates to better patient outcomes. It's a delicate dance of science and empathy. We need to understand the anatomy and the physics of how X-rays work, but we also need to connect with the person in front of us. An X-ray is not just a technical task. It's a human interaction that requires communication, compassion, and a steady hand. Taking a few extra moments to get the position just right before activating the beam is an investment that pays dividends in diagnostic clarity, patient safety, and a more positive healthcare experience. The chest X-ray is one of the most common diagnostic images, and for good reason. It gives us a window into the heart, lungs, and major blood vessels. To get the standard view, we ask the patient to stand facing a flat panel, which is the detector. We want their chest pressed firmly against it. Their feet should be shoulder-width apart for good balance, and we'll ask them to roll their shoulders forward. This simple action might feel a bit like giving the detector a hug, but it serves a very important purpose. It moves the shoulder blades out of the way of the lung fields, giving us an unobstructed view. Once the patient is in this forward-leaning position, we need to think about their chin. We'll ask them to lift their chin up and rest it on top of the detector. This prevents the shadow of the jawbone from creeping into the top part of the image, where the apex of the lungs is located. It's a small adjustment that ensures we can see the entire lung from top to bottom. To help the patient feel steady, we encourage them to place their hands on their hips with their palms facing out. This position helps to further rotate the shoulders forward and provides a stable base, making it easier for them to hold still. Communication is absolutely vital at this stage. We need to explain what we are about to do. I'll usually say something like, "All right, I'm going to ask you to take a very deep breath in and hold it for me. Don't breathe out until I tell you to." Taking a deep breath is crucial because it fills the lungs with air, expanding them fully. This expansion makes the lung tissue less dense and provides a much clearer, more detailed picture of any potential issues. It's like inflating a balloon to see its true shape and size. A partially deflated lung can hide important details from view. Finally, just before we take the image, we give the instruction, take a big breath in, hold it, and then the exposure is made in that brief, still moment. Immediately after, we say, "Okay, you can breathe normally now." This clear sequence removes any guesswork for the patient and ensures we capture the image at the peak of inspiration. By carefully guiding the patient through these simple steps, chest against the board, shoulders rolled, chin up, and a deep breath held, we can consistently produce high-quality chest X-rays that provide doctors with the clear information they need to make an informed diagnosis. When it comes to imaging something as intricate as the hand, precision is everything. Even a tiny bit of rotation can cause bones to overlap on the image, hiding a subtle fracture or a sign of arthritis. For a standard hand X-ray, we typically start with the patient seated comfortably beside the table. This is important. An uncomfortable patient will find it difficult to keep their hand perfectly still. We want their arm to be supported on the table, with the shoulder, elbow, and wrist all at the same level to avoid any distortion of the anatomy. The most common view is the postero-anterior, or PA, view. This simply means the X-ray beam enters from the back, or posterior, of the hand and exits through the front, or anterior. We ask the patient to place their hand palm down flat on the image receptor, which is like a digital film cassette. We then gently ask them to spread their fingers slightly apart. This separation is key because it prevents the bones of the fingers, known as phalanges, from overlapping. If the fingers were bunched together, it would be impossible to assess each one individually for any potential injury or abnormality. Next, we often need an oblique view, which gives us a different angle to look at the bones. For this, we ask the patient to rotate their hand almost as if they were about to catch a ball, until it rests on the detector at about a 45-degree angle. We can use a foam wedge to help them hold this position comfortably and steadily. This angled view is fantastic for revealing fractures that might be invisible on the flat PA view, as it changes the way the bones are projected onto the image. It's like walking around a statue to see it from all sides. Each perspective reveals something new. Finally, a lateral or side view is often required. The patient positions their hand on its side, with the thumb pointing upwards as if they were about to give a thumbs up. This view is excellent for looking at the alignment of the bones and for detecting any foreign bodies, like a splinter of glass or metal. Throughout all these views, we must ensure the entire hand, from the tips of the fingers to the wrist, is included in the image. By carefully guiding the patient through these three simple positions, flat, angled, and side-on, we can build a complete and detailed picture of the hand's complex structure. The knee is a complex, weight-bearing joint, so getting a clear X-ray is essential for diagnosing everything from sports injuries to arthritis. Patient comfort and stability are paramount here, as even a slight wobble can blur the crucial details of the joint space. For a standard front-on view, known as the antero-posterior or AP view, the patient will typically lie on their back on the X-ray table. We want them to be as relaxed as possible, so a pillow under their head is a good idea. We then ask them to fully extend the affected leg. To get a true image of the joint space between the two main leg bones, the femur and the tibia, we need to position the leg correctly. We gently rotate the entire leg inward by about 15 degrees. This might feel a little unnatural for the patient, but this slight turn ensures that the lower leg bones are parallel to the image receptor. Without this rotation, the joint space might appear artificially narrowed, which could be mistaken for a sign of arthritis. We can check our alignment by making sure the kneecap or patella is centered directly over the end of the thigh bone. Next, we need a side view, or a lateral view. For this, we ask the patient to roll onto their side, with the injured knee being the one closer to the table. We'll then ask them to bend the knee to about a 30-degree angle. This slight flexion helps to separate the different parts of the joint, giving us a clearer view of the patella and the space behind it. We often provide foam pads or pillows to place between the knees for comfort and to help keep the injured leg stable in the correct position. The other leg is usually moved out of the way, either forward or back, to prevent it from showing up in the X-ray. In some cases, especially when assessing for arthritis, doctors may request weight-bearing views. For these, the patient will stand up, putting their full weight on their legs. This shows how the joint space behaves under a natural load, which can reveal a narrowing that isn't visible when the patient is lying down. Throughout every step, clear instructions and reassurance are key. Explaining why we are asking them to turn their leg or bend their knee helps the patient become a cooperative partner in their own imaging. A little bit of explanation goes a long way in achieving that perfect diagnostic quality image of the knee.